Thank you. Thank you for the opportunity to speak to everybody today. We have an excellent panel for you today of health leaders that have worked with Nuance over the past few years, and I think it's a great opportunity to get some of their insights into some of the things that they've been able to achieve, as well as some of the things that they've done in the past to improve a lot of the things that they are doing in the world of physician documentation. My name is Tony Oliva. I am the Chief Medical Officer for the Clinical Documentation Improvement world at Nuance, and have an opportunity to interact with these leaders at many times, and I hope that we'll be able to have sort of a robust discussion. This will be more interactive than presentation, and also hope we can get some questions from the audience to sort of direct some of the conversation to things that may be of significant interest to you. So to start off, I thought what we do is give our panel a chance to introduce themselves. We'll start with Dr. Hanna from Universal Health Services. Dr. Hanna?
Hi, good afternoon. Thanks for having me. It's a great opportunity to be able to speak to you today. A little bit about myself. I am an internist by training. I worked as a hospitalist for about 10 years. I've joined UHS about 7 years ago. For the past 5 years, I've been the Chief Medical Information Officer over the Acute Care Division. UHS is a Fortune 500 company headquartered in King of Prussia, just outside of Philadelphia. We're about $10 billion in annual revenue. We have two divisions, a total of about 350 facilities between acute care and behavioral, located mostly in the U.S., but we also have some in the U.K., and we have about 81,000 employees in our organization. Thanks for the opportunity to be here.
Great, thank you, Dr. Hanna. Next, we'll pass this on to Dr. Wiederholt from Adventist.
Thank you. I'm Dr. Michael Wiederholt. I'm the Senior Medical Director at Adventist Health System. I oversee CDI as one of my areas of responsibility. I got my start in healthcare actually as an EMT when I was 18 years old, and I went on to become a pediatrician, and then I got started on the IT side of administration. But for the past 2 years now, I've been leading the documentation efforts for Adventist Health System across our entire health system. As you'll see on the screen, we're 45 hospitals in 9 states. For the system that we're talking about now, we just focus on 8 hospitals. The Colorado is actually run separately as a different organization. But you see on the screen that we are quite a large organization. We are the largest Protestant healthcare system in the country. You can go ahead and go to the next slide, Dr. Oliva. And for our hospitals, and that's what I was just referring to, we have 40 hospitals that use Cerner and Clintegrity, and with that we have now 112 nurses. That has definitely grown over the past couple of years. When I first started in my corporate role here, we had about 75 nurses. We've definitely grown just in the past 2 years for our CDI footprint. Thank you very much. I look forward to the discussion.
Great, thanks a bunch. And John Dahl, who is the CFO for Barnabas, and if you want to introduce yourself, that would be great.
Sure. So I am the token finance person on the panel, so thank you for having me. It's actually RWJ Barnabas Health. Our system under that name is 2 years old. The resulting merger of Barnabas Health and Robert Wood Johnson Healthcare System. We're the largest healthcare system in New Jersey. We have 11 hospitals. I've been with Legacy Barnabas Health, where Dr. Oliva first met me, for just about 9 years, and prior to the role as CFO, I've had deep experience in revenue cycle where we first rolled out the Nuance system. And then when our system came together, I was actually in charge for integration and really a host of things in forming the new merged system, governance, IT systems, and a bunch of things. And we rolled out the system across all of our hospitals, which are located in the core of our state and the most densely populated area of New Jersey. We're a $6.5 billion system in terms of total assets, a little over $5 billion in revenue, and happy to be here.
Great, thanks. So I want to just set the conversation a little bit, talk a little bit about sort of what the world looks like out there, and what some of the things that you're likely facing, and then try to link that to some of the solutions that Nuance has, as well as some of the things specifically that some of the leaders have done to sort of address some of these issues. And we're all familiar with these issues and problems. Clearly, capturing appropriate reimbursement is a challenge in any system, especially under the DRG system, which brings us to the whole idea of clinical documentation improvement, estimating about 4 to 8% of net patient revenue being missed because of non-capture of appropriate reimbursement. You know, physician productivity, responding in retrospective ways to queries is a huge issue, not just in workflow, but in time. We realize that physician burnout is a significant problem, and when we ask health systems what one of their biggest issues is for them going forward, this tends to rise to the top many times in our discussions. We're seeing lots of more penalties associated with quality. Most of them focused on the acute side, but that's beginning to slide into the ambulatory and physician office environment. Denials continue to be a chronic and persistent problem for organizations, whether it's commercial denials or whether it's RAC-related issues. Documentation obviously plays a significant role in there, and clearly margins have continued to shrink because of challenges around the capture of revenue and actually access to revenue. So we're continuing to see that being challenged against us. While we've done a lot in the last 10 years to cut cost, we essentially are just treading water and sometimes losing that battle and trying to keep up. As we think about getting documentation right, our focus has been how do we do that and how do we get it right the first time? And then how do we give appropriate guidance for our physicians and our CDI teams to both get the documentation right the first time, but use that documentation and information to get the most out of the documentation, both from a coding as well as a quality approach. So for physicians, how can we put some of that into their workflow up front? How can we put that into technology supported solutions that help them at the point that they are documenting rather than having to rework things at a later time? And then how do we help our CDI teams to work within their world and help them be more efficient, prioritize the activities that they're doing, and improve the ease by which they can interact with the physicians and get appropriate documentation done. So that's sort of where our world has been focused in trying to address some of these issues. And luckily, we have leaders on the line who are on both sides of that. Some who have, at this point, managed this problem specifically with CDI, traditional CDI-type activities. And then we also have Dr. Hanna, who's actually begun working on this from a upfront technology solution-driven approach. So to sort of get the conversation rolling and maybe sort of get some discussion and questions sort of driving, what I'd like to know from each of the leaders on the phone, what would you say was the key problems you were trying to address as you began your partnership with Nuance in the CDI world? And maybe we'll start with Dr. Wiederhold.
Well, our first key driver with this was financial focus. That goes back a number of years. We've been a partner with Nuance for a long time, and it really was at that point financially driven. It was to improve the case mix index so that we have additional revenue or not leaving money on the table. Now, that being said, we definitely have moved past that. I think we have our new driver and problem to be addressed is really focused around quality, and the new attitude that we have here at AHS is that if we do good quality-wise, then the financials and the case mix index will follow suit. So we've actually had a shift here, and we actually are having some difficulties in certain pockets, continuously reinforcing our shift of we were financially driven, and that was actually something very strategic when it reported, since CDI has been reporting to me now for 2 years. Initially, it was under revenue cycle, so our CEO made a very firm stance on this is going to be clinically focused, and the quality will be the key aspect, followed by the financial. So, like I said, initially we started for the financial. I think that's how most hospitals get started in, but now we're trying to do more for the quality aspect.
Great. Mr. Dahl, would you sort of concur with that, or did you have some other sort of burning issues you were also trying to solve?
Sure, thank you. I think our initial start was essentially consistent. I would say we had a revenue and a quality need. We were concerned about some of the quality scores at our sites, and there was always an allegation that we were under-documenting, and that was impacting things like our mortality scores, so that was a driver. There was a financial ROI in the investment, and like I'm sure all the others on the call, those things quickly evolved to other needs. I'd say the most recent change for us has to do with timeliness. So what we're seeing more and more are the payers wanting to reach into our electronic health records real time while patients are in our facilities, and retrospective queries and not having things documented up front clearly wouldn't have the information available as to the severity of their members or our patients' illnesses, which has impacted denials and a whole host of other things. So really, a real-time documentation improvement program has been a change in focus for us in addition to the revenue and quality drivers.
Awesome. Dr. Hanna, you have a little bit of a different, I think had a little bit of a different set of goals, choosing to look at technology. Can you talk about that a little bit?
Yeah, absolutely. I mean, similar to other organizations, I think, you know, the no margin, no mission is important, but I think the main driver within our organization was the fact that we are doing good work, but our quality scores that is becoming published and available are not showing that work. Our alignment with our physicians, the majority of our physicians that we work with are private physicians, and making sure that we have that relationship. Most of the doctors look at you know, CDI and quality of documentation as something to make more money for the hospital, and their interest in making UHS more money is really not a priority in their day-to-day operations. looking at documenting the quality of care that we're doing and providing a tool that is in their workflow, that is easy to deploy, and I don't have to have a high spend on trying to train them and explain to them all the sort of the definitions and remind them of this. We found that the electronic tool would be a great, efficient way to deploy this in our environment.
So to sort of bounce off of that, why don't I start with you, Dr. Hanna? How was the physician acceptance of the technology when you implemented it, and what were some of the things you had to overcome and some of the challenges you had to deal with?
Yeah, so traditionally, and when you're deploying any new project, especially an IT project, people run as fast as they can. And so whenever people see the CMIO and they look the other way and they start moving in the other direction, I think in the past 4 or 5 years, we started to see a change in that. We started improving the technology that we provide to our physicians. It started with physician documentation deployment that we had. We had good success, good adoption, voluntary adoption. Most of our hospitals' projects are deployed in a voluntary manner, so to get physicians to actually want to use the tool. And the conversation started a little bit about what tools can you provide me that may help me? And we focus on the what's in it for me. Our project was I guess, lucky enough to be aligned with MACRA and MIPS legislation. So my presentation to the physicians was mostly about how their measures, how their quality is being evaluated, how their payment and reimbursement from CMS is going to be dependent on their quality scores, and how is benchmarking happens. And in the past, maybe what the coders put in on the bill was not important to you. You looked at it as just a way to make money for the hospital. But starting today, it's actually been happening for a while. It's actually going to impact your complication rate, your mortality rate, because it's all risk adjusted based on what that coder puts in. So the conversation really has been around, let's talk quality, and let's talk how do you prove to the world and to your future patients what quality do you provide, and how is the quality of your outcomes being measured and being benchmarked. And I think the conversation just changed from UHS is trying to get more money to UHS is looking for physicians who are able to prove the quality of care that we provide.
Awesome. And John, your program was more of a traditional CDI program, and I'm sure there was physician pushback. I remember as I did education and implemented during implementations. What were some of the things that you as an organization did to manage some of those problems?
Yeah, I'm sure you still have some of those scars and remember it well. I think one of the things, before I answer the question directly, to point out, and maybe I should have done this in my introduction, is that although we're a geographically tight and relatively small system, our facilities vary in size and scale from large academic centers to very small community hospitals. And the acceptance and issues were just as varied as our facilities, ranging from doctors who fully embraced the change to those that also were concerned about an IT or finance-driven program, to those who quite honestly had a little bit of a fear around documenting some of the conditions because they didn't like the words respiratory failure. I think the one commonality in addressing it was really the process that's embedded in the program. So physician-to-physician discussions, as opposed to a finance person leading that message, were helpful universally. I think the other thing that was very helpful was in every instance, we converted from either a homegrown or a competing CDI program. And the difference of having a fully vetted, educated clinician running the program to, in some instances where that was not the case, really had a profound effect on the dialogue between the CDS resource and the physicians as we began to have the programs take hold. So I think it was really those two things, the quality of the staff and how they're supported, and the ability to leverage physician-to-physician education within the program.
Great. And Dr. Wiederholt, sort of same question at Adventist. How did you handle some of those challenges that are pretty consistent with these programs?
The challenges are pretty consistent with what we've had for our hospitals. We go down to critical access hospitals to a 1,700-bed hospital, so there's definitely this very similarities to that. And then we have this same issue that Dr. Hanna brought up, where most of our physicians are not employed by us, so it's a different buy-in for them. So the one thing that we tried to do a lot initially was show the ovary mortality scores for our hospitals, and some of them were not what you would have expected, even for having top benchmarks for other external measurements, such as U.S. News and World Report, where we may have been a good hospital, but if you look at our ovary mortality, we weren't so good. So we tried to focus a lot on that and use that as a driver, and we had a lot of success with that, showing where the documentation really wasn't supporting what was happening with your patients. And along that same line, we're also now trying to focus more on ovary length of stay. There's been a big push at the hospital for length of stay and bring down length of stay, and we've tried to shape that argument a little bit to say it's not just bringing down length of stay, it's also having the appropriate length of stay. Because when we do our ovary length of stay, some of our hospitals definitely are messed up on the expected side of that, which all, of course, goes down to documentation. So when we have our physician discussions, we try to pretty much focus on those two metrics, on working on the mortality and the length of the stay, because the physicians truly don't care about the hospital making money. They all love having a nice doctor's lounge, having free food in the cafeteria, but they don't always see it eye to eye when you say, well, that's where that comes from. But showing how they are not perceived as a top-tier physician on those metrics really gets their eyes to pay attention to the importance of the documentation that we have in there and having a partnership with the CDI team.
Yeah, and that sort of leads into sort of the next sort of question. And all of you are clearly very metric-driven, and it sounds like your organizations are very metric-driven. So do you feel that you have begun to achieve some of the goals that you had set around the metrics? What are you really focusing on around those, and how has Nuance helped you in sort of helping you get to those goals? Dr. Wiederholt, why don't you start if possible?
Sure. So I'll start with an example I give multiple times on how Nuance has helped us. I actually have never told Nuance this story before, but we've had an issue before with the joint bundled payments, and with all our hospitals, it's hard to keep track with what's happening in each one, but our analyst for one of the our analyst for the bundled payment initiative came and said, hey, we're having trouble with 2 of our hospitals. And the first thing I said was, have you looked at your with and without distribution, looking at the distribution of with CCMCC and without? And she said no, so she went and calculated it for all the hospitals and then showed me the 2 that she had trouble with. And it was very interesting that the 2 she had trouble with, in my mind, had very high numbers of without. So I pulled out the track analysis for those 2 hospitals and looked at the DRG proportions, so I could immediately see the proportions of the peer group distribution to these 2 hospitals, and 2 hospitals were in different peer groups, and I could immediately show, look, this is either poor documentation or there's some sort of self-selection where they're having a healthier population there during this time period. But that was very invaluable because the hospital was just coming up with other reasons or didn't really know what was going on. I think it had 100% to do with the documentation. In fact, for those two hospitals, I had someone here at the corporate office, one of our corporate CDI nurses, review all those charts for that quarter and still found about 10 or 11% of those cases that were without should have been with CCMCC, and then they would have been at peer group. And it was just that it was either missed or they didn't have enough CDI staff, but that documentation was invaluable to be able to compare the other peer groups. Otherwise, you're just comparing against MedPAR, and that's not really worth much of anything.
Right, right. Great point. Any other thoughts there? Or how do you think you've done overall as far as meeting the goals and metrics that you had?
So overall, for meeting our goals and metrics, so we are not there yet. We're kind of like in a rebuilding year, I would say, right now as we increase our staffing. So once it came under more tightly corporate control, we've been trying to first off, we rebranded and we called ourselves Integrity instead of Improvement. And then we were just trying to focus a lot on this whole year on education of the CDI nurses. We had a number of nurses that weren't doing the best they could, and we partnered with Nuance once again to have increased education. We had education a number of years ago when this is before me in this role, and then they stopped the education with Nuance once again before me, and then I came on board and realized that our CDI nurses weren't as educated as we would like, so we reinitiated a contract with Nuance to do education with the nurses. We require everyone to do the week-long onboarding program, and we hire new nurses, which is really helpful in getting them up to speed, better than any boot camp. We then have them do the strategy academies every month, and we actually do create a test in-house to ensure their competence on that. And then we really are focusing on the clarifications that they're doing, the quality of the care clarifications. And then we partner with our results manager from Nuance to set higher benchmarks for where the case mix index should be or how many clarifications that we're sending out to the physicians. So that's actually been paramount. So in terms of the metrics, I'm not totally happy with where we are. We are on a journey right now in recreating ourselves because I think we slipped a little bit, but having us partner once again more tightly with Nuance has definitely helped us in this year. We've already seen it with the severity of illness and the risk of mortalities going up or being shifted more to the right-hand side with more 3s and 4s.
Great, great. John, your thoughts on sort of where your journey's been and how you're doing and where Nuance has been helpful in supporting you?
Sure. I think there's two separate answers to that. As it relates to our legacy Barnabas Health program, what we had were two distinct sets of metrics that really are a part of the program overall. The first were a series of process metrics. You know, how many of the cases actually got a review, what our response rates from physicians were, whether or not our coders agreed with the CDI assessment. And our very first site to go live, and Tony, you'll remember this, we had poor results in all of those. We weren't getting to all the cases, the coders weren't agreeing, physicians were not responding, and how we were helpful was with on-the-ground educators really pushing so we refine that process, and then that refined process really survives in the program that exists today. We also measure outcome scores, which I'm sure everyone would imagine are CMI, and then the overall capture rates within the DRG triplets and other pairs. As it relates to other metrics, you know, one of the things that I was charged with prior to this role in the Office of Integration was achieving savings targets contemplated by our merger, and we had CMI improvement targets relative to the rollout of the program. So we had a very specific way of measuring financial outcomes. I'm happy to say that as we rolled the programs out, we hit everything what we wanted, and how Nuance helps us today is the CDI program really is about having your documentation, not gravitate back towards a mean or an average, and making sure it's the appropriate documentation at the highest level. So when we see that occurring, our contract and agreement is annual health checks. So we reset facility-specific goals so those teams are re-educated and refocused on any area where we see that gravitation back to the mean.
Great, great. And are you fairly confident that you're sort of getting to where you want to be?
I would say overall, yes. And again, the challenge is it ebbs and flows. So it's a living, breathing thing. So if you don't stay on top of it, you can quickly lose some of that benefit.
Great. Dr. Hanna, your thoughts on the same question?
Yeah, absolutely. So starting the project, we had process measures that we wanted to track the adoption, what percent of our patient population is covered as a surrogate of how many physicians do we have the right number of physicians involved and participating, what's the response rate, are they responding to the automatic queries, then what's the agree rate. We also had the outcome measures, so how did we impact our severity of illness documentation, complexities of our patient, and our case mix index. So I'm happy to report on that the adoption measures has actually exceeded our expectations. We already got to the 80% response rate that we wanted to. Many of our facilities are covering 80 to 90% of their patient population, meaning we have a good physician pool that's using the tool. The agree rate is around 50%, meaning of every 2 queries that we send to the physicians, they're agreeing to 1. Sometimes that goes up to 60–65%, which is pretty good for an electronic, automated, AI-driven decision support system. We're getting about 10,000 to 12,000 queries a month firing to our physicians, and we have not seen any negative feedback with alert fatigue or complaint on that front. As for the outcome measures, we've seen a trend upwards in the severity level of documentation year over year, and that continues to go up. We have not seen a plateau to that at this point. So I think it's a continued improvement. We've seen a similar graph for the risk of mortality, and we've seen really good results with the observed over expected mortality numbers, again, year over year compared to the year before we turn on the tool. So I think the leadership here is happy with the outcomes, and the request that I always get is, can we add more diagnosis to the tool?
Right, right. So that's great. I think this might be a great time to see if we can maybe take a little break for some questions before we go on to maybe future state. If there's any questions from the audience, some thoughts, or what we might be able to get some insight from the panelists.
Thank you. And ladies and gentlemen, if you wish to ask a question from the phone lines, please press star then 0 on your touchtone phone. If you're using a speakerphone, please pick up the handset before pressing those numbers. Once again, star 0 if you would like to ask a question.
Any questions out there from the group?
And I'm showing no questions from the phone line.
Okay. All right, great. So let's sort of move on to future state. Sort of thinking, where do you want to go? Because as I sit back and look at this world of documentation as we continue to transition to more and more value-based reimbursement, value-based care, more risk being taken by organizations, and the competition is always about being better than the average of everybody else, right? Because that seems to be the way the value is being paid out. And everybody's sort of doing this. Everybody's trying to move down this road. What do you all see as, what do you see in the next couple of years for you and your organization, beyond maybe just the acute side to the ambulatory side to resource challenges that you may have, both human resource challenges as well as just the FTE challenges of cost. So maybe go backwards again, start with Dr. Hanna, and maybe some of your thoughts on where you see this world and where your organization is looking to go to sort of keep pace and stay ahead.
Yeah, absolutely. I mean, I see a great future, and many of us do, for artificial intelligence and decision support at the bedside, if you will, in the workflow for the physicians, for the clinicians in general. I see a larger involvement and engagement in terms of HCC, quality of documentation, natural language processing, things that helps the clinician by the bedside in a timely fashion, present them with a set of tools. Hey, you forgot to add this HCC. Hey, you may want to clarify this diagnosis. Hey, maybe the patient meets these qualifications to meet this diagnosis. So we are very interested in embedding that type of artificial intelligence decision support in the clinician workflow as much as we can possibly do without bombarding them with lots of alerts. I think presenting it in the workflow in a nice manner, like we do with DQR or some of the suggested diagnosis, without interrupting their day, would be what I would see as the future. It's also, in my mind, as the most efficient way to deploying this. You don't need to worry about the staffing, the training, but also it's a timely way of providing the decision support.
John, your thoughts on the future, where you see things going? All of you are sort of in different markets as well, so sometimes there's local challenges and issues, but what are your thoughts on RWJBarnabas and where you're going?
So our program originally started with Medicare only. We've expanded it to include Medicare Advantage, and we're expanding it to include all payers. So the challenge with that expansion is coverage, staffing, and the economics of that. Even finding all the CDS resources to do that would be a challenge, aside from the cost. So the two things that we think are critical as we evolve are, as suggested a moment ago, some level of automation of that process, and then also using elements within the AMR to drive workflow. So, tools that highlight cases that are more likely to need a clarification than others and putting them at the top of a queue for a CDS resource are critical enhancements in the technology that we're working to deploy.
Great. And do you see that happening now, near future, sort of right on the horizon, or do you see that down the road a little bit, or are you?
Well, we're piloting some of those solutions now, so it's a real near-term thing. Depending on the outcome of our pilots, we'll expand.
Dr. Wiederholt, your thoughts?
Well, I wanted to basically concur with John's statements. So we at AHS less than a year ago made the decision to start reviewing all DRG payers. So that expanded it past Medicare, Medicare Advantage, Medicaid, Managed Medicaid, and then commercial DRG payers, which seems to keep growing. And now there's the discussion of all payers, and that's a different discussion, and some people don't like the fact that we might be reviewing self-pays because those don't always have the same drivers economically as others do, because the other payers probably will go to DRG at some point, so it's just preparation for that. But that brings up the whole staffing challenge that John also mentioned, and where are we going to find all the CDI nurses, and where are they going to sit, and then worried about the quality of them. And as I mentioned one time to one of our leaders, if we hire several hundred people, we're going to need an equal, or not an equal, but a sizable amount just to manage and lead those teams for the entire health system, so it keeps growing and growing, and let alone we'll have the issue of weekend coverage. Right now, almost none of our CDI nurses work on the weekend, and most of them very much like having a 5-day-a-week job, so it would definitely be a transition for them to work 1 or 2 days over the weekend, and the weekend coverage would probably be somewhat different than the weekday coverage, usually getting patients that are being discharged that day or that will get missed, because that's where we notice a lot of our quality right now are kind of slips or one-offs, or patients that are admitted on Fridays and then discharged on Sunday or Monday, and they never get a review by the CDI team. So that's one thing that we're focused on. And the other thing that I'd like is the artificial intelligence that was mentioned previously, and I care more about the confidence level of which charts that we can ignore. I do like the prioritization of charts and knowing which ones have higher opportunity than others, but I really would have more confidence in having the system just say, ignore these charts. There's no reason to even look at them. And then we can just have the team focus on a smaller amount of charts.
Great. So clearly AI is sort of out there in the future for everybody, and I don't think that's a surprise with just the challenges that we face from a resource perspective, especially human resources, and the needs to keep up. Before we go to sort of final questions from the group, you've all chosen to partner in some way with Nuance. In just sort of a few comments, what were some of the things that gave you confidence to partner with Nuance, and some of the things that you saw as differentiators that gave you that confidence to partner with Nuance in areas that you have? Dr. Wiederhold, we'll start with you.
I'd say one of the big things that I like about this is the peer groups. The peer groups are instrumental for us in judging the performance of our hospitals. As I kind of alluded to earlier, the MedPAR data is there. It's old. It's basically just average hospitals, and we strive to be more than average. So that part is just paramount, of being able to see what all the other hospitals are doing that are similar to us. And then all the data sheets, all the track analysis reports that come out every month. We don't have as many hospitals as Dr. Hanna, so I would hate to imagine how many reports they get there, but I get the report for every single hospital, and obviously it gets filtered away to a folder automatically for me. But having that information at your fingertips is priceless. And when we have any kind of discussion about different hospitals, what's going on, being able to look at them, see where they're at, compare them against the peer group, and then you can also judge of different service lines depending upon what that hospital does or doesn't offer. You can kind of discount that and know exactly how that hospital is doing. That in my mind is paramount. And then, as I mentioned earlier, the education. I think the education is wonderful. It's one thing for me to say something, or for the corporate office to say something, and then it's corporate doing something, but having an external third party like Nuance saying that something is right or appropriate or educating a certain way, for us, that's also invaluable.
Awesome. John, your thoughts?
I agree with the comments on the peer groups, very helpful, and I'm probably not going to use the right terminology, but effectively the job or learning aids for the CDS resources that allow them to get more specific education on the documentation requirements for specific disease entities are a clear differentiator.
Great. Dr. Hanna, your thoughts on?
Yeah, absolutely. I mean, I think the decision to partner with Nuance came down to two key items. I think one of them was partnership. We've had a very good collaborative approach and a success with the deployment of Dragon Medical One. We felt that the Nuance team was dedicated to the success of the project, and I think we felt that we have a good partnership and we're together collaborating to the success. The second was sort of the technology, and we're looking for a vendor who has the CDI knowledge, but also has the artificial intelligence capabilities. And you hear a lot of vendors talking about, you know, we can develop AI, and there is a lot of discussion out there. So partnering with somebody that we can trust, and I don't know if I said this before, but I was in a trip to China a couple of months ago, and we met with their AI publication, and as many of you know, China is working hard to compete in the AI space. And outside of Google, Nuance with the other U.S. company that was mentioned, where the Chinese are keeping an eye on sort of their development. And I felt proud that that's one of my partners that I work with. So I think those two key components that we believe that we're partnering with somebody who is good at collaborating and partnership, and we have evidence to that. And then the second part is somebody who can actually deliver on the AI promise.
Great. Thank you. Thank you all for your comments. I think at this point, why don't we see if there are any questions from the audience? Open that up again.
Thank you. And once again, if you would like to ask a question, please press star then 0.
Hey, Tony, while we're waiting for folks to dial in to ask questions, there are a couple that came in through the chat. So the first one looks like it's for Dr. Hanna about the numbers around the number of alerts that the solution was providing. So 10 to 12,000 seems kind of high. Can you put that in a little context? How many, across how many admissions, how many facilities? And then related to that, just expand a little bit further on the mortality numbers, the impact on the documentation, and how you think that work actually had an effect on mortality, or were you just referring to the OE mortality index?
Sure. And so the 12,000, 10 to 12,000, I have 26 acute care hospitals, so that's firing in the 26 acute care hospitals. We actually, I didn't speak to that. We did have a metric that we developed to look at the number of alerts per node sign. And so we developed, if a doctor created 10 notes, how many of them are they being queried on? And initially, as we were piloting this, it was about 40 to 50%, meaning every other note they were getting a firing. We were a little bit worried about the alert fatigue, but as people started to learn, we started seeing that, and now we're about 12% firing rate. We have not had a lot of or any pushback from our physicians about alert fatigue. When we study alert fatigue, it's two components: is how many alerts are you getting, but also how valuable do you find them. So if you're getting a lot of alerts and you're agreeing, 1 in 10, you see a lot less value. If you're getting a lot of alerts and you're agreeing with 50 to 60% of them, you see enough value that it does not disrupt your workflow. So that part we were pleased not to see a lot of alert fatigue. The second question about was it the risk of mortality or the observed over expected?
Yeah, I think maybe just to clarify what the impact that you saw was on OE mortality, and then is there a correlation to see any impact on mortality itself?
So this is hard to measure, right? Like that correlation. So we can speak to those two are related or correlating versus causating. You know, is it the cause or not? You know, we continue to try to improve our care. We continue to try to provide better processes, look at errors. But when we plot the graph, the observed over expected mortality, and we put in the 2016, the year prior to implementation, and then the 2017, the year of implementation, we can clearly see a statistically significant improvement and a drop in the observed over expected mortality. So we're at overall, I think 0.75 is the last data point that I have for December of 2017.
Okay, that's great. Thanks very much. There's another question. Maybe each of the team could weigh in on this, but can you share the baseline competence and educational background requirements that you have of CDI staff that you're evaluating to bring into your organization? How do you ensure that only high-quality CDSs are hired?
So I'll take it. I guess that you're addressing the entire panel. Embedded in the program
you go ahead.
is an actual coding or coding proficiency test. So all of our candidates, even the incumbents, are required to take that, and we have a passing score threshold that if they don't get a passing score in the first attempt, they can't retest for a year, and they're disqualified from the position. Our job description also, and we debated this heavily because a lot of our legacy programs had foreign-trained physicians that weren't licensed and other clinicians as part of the program, but we found the program is most successful when staffed by registered nurses. So we only allow RNs into our program. So those are really the two main drivers of selection.
So at Adventist Health System, we follow a very similar process. The only difference is for several years we kind of did away with the test, not by choices because hospitals were able to do what they wanted to do, and a number of them just hired who they wanted to hire. And our quality of CDI nurses definitely suffered. So a year ago we reestablished the fact and mandated from corporate that you have to take the test and you have to pass. And that's definitely seen an improvement in our educational level of our CDI nurses. And once again, we also require nurses throughout the health system. And it also improves the ability to quickly come up to speed on how their role has changed from the bedside to being a CDI nurse. So the test has been paramount for us for doing that.
And this is Deb, and I don't have anything else to add to what the panel's already mentioned.
Okay, great, thanks. Another question for you, Dr. Hanna. In terms of the types of physician specialties who you found may have taken to using the automated technology maybe more readily than others, could you talk a little bit about where you see across the organization which types of physicians are using it, which have maybe been reticent to start but then have realized the value and started to use it, and then are there groups of physicians who just are not using it, and maybe a little comment about what the challenges are there?
Yeah, that's a great question. I mean, when we initially started the pilot, we opened it up to all specialties, and then we realized that the value and the algorithms are really built if you're the primary attending of that patient. So from a U.S.-centric approach, the hospitalist, if you're the primary care physician, if you're the primary surgeon, if you're the intensivist, this tool made a lot of sense to you. If you're the nephrologist who's consulting on a patient, it may not make a lot of sense to get a malnutrition request or a question. So we try to cover our patients through the primary attending of records. And just covering the hospitalist, that most of you, your hospitalists are consulted on your sick patients. and it's really the high-value patient. So if you have a simple case on an orthopod service, they're not likely to get the hospitalist on board if that patient is a simple, straightforward, and you may not need DQR to evaluate that case. But you most often have the hospitalist following a complex patient, and then DQR follows that hospitalist to every single patient that they see. So we've gotten a good coverage of our patient population. As I mentioned, somewhere between 70 and 90% of the patient population are covered just by covering hospitalists, residents, intensivists, and some of the primary services that they may admit their own patients.
Very helpful. Thanks a lot. Tony, we're just about at the top of the hour, so I don't know if you want to wrap with some parting comments.
Yeah, I want to thank everybody for joining us today. I especially want to thank our panel. Your insights have been invaluable, and we continue to enjoy and look forward to continuing our ongoing relationship with you and your organizations and Nuance. So thank you all very much for your time, and thank everybody that joined us today.
Thank you. And ladies and gentlemen, that does conclude your conference for today. Thank you for your participation and for using AT&T Executive Teleconference Service. You may now disconnect.